So coming to the second part of periodontal case sheet recording, hard tissue examination. So examination of the dentition is very important with respect to the size, shape, alignment of the teeth and their vitality should be noted. Deviation from the normal indicates the reason for periodontal problem. So it can be explained under various wasting diseases. Any gradual change of tooth substance characterized by the formation of smooth polished surface without regard to the possible mechanism of this loss. So it can be defined under different terminologies, that is attrition, abrasion, erosion and abfraction. What is attrition? Attrition is the occlusal wear resulting from functional contacts with opposing teeth. So you can see in the picture that a clear cut, like the incisal edges will be attreated. So this is attrition. And next, coming to the abrasion, there is a pathologic loss of tooth substance induced by mechanical wear other than that of mastication. Usually toothbrushing, vigorous toothbrushing, horizontal toothbrushing technique will end up in this type of abrasion. And next, coming to the erosion, sharply wedge defined, wedge shaped depression in the cervical area of the tooth surface. There is a main cause due to the decalcification by the acid beverages or citric foods and acid regurgitation. So this erosion can happen. And then coming to the abfraction, there is a pathologic loss of hard tissue substance caused by biomechanical loading forces. You can see that in this picture there is a notch. So if there is any like notch type like destruction of tooth surface, it can be categorized as abfraction. So coming to the occlusion, deviation from normal occlusion is a potent factor in the production of periodontal disease. So any deviation from the normal occlusion can affect the periodontium. So in this case, like can be the various findings and which suspected periodontal conditions, and wear faces that like teeth take up increased forces, excessive mobility of teeth, that is occlusal traumatism can occur. Loss of teeth might lead to pathology migration or supraeruption of opposing tooth. Procline anterior teeth with incompetent lip and presence of mouth breathing might lead to drying of gingiva and it might lead to gingivitis. Coming to food impaction, forceful wedging of food in the periodontium by occlusal forces, that is called impaction, food impaction. So you can see that in this picture there is an open contact in between the teeth, and this upper opposing tooth, that is with having plunger cusp, act as an agent to wedge the food inside the space. So this is food impaction. So there are various factors that lead to food impaction: uneven occlusal wear, opening of contact point as a result of loss of proximal support or extrusion of tooth, congenital morphological abnormalities, improperly constructed restoration, and excessive anterior overbite. So coming to the trauma from occlusion. So when the occlusal forces exceed the adaptive capacity of the tissue injury results, and the resultant injury is termed as trauma from occlusion. So there are two types, there is primary and secondary. So when TFO is the result of alteration in the occlusal forces, there is an example, you can see that in the first picture there is alteration in the occlusal forces due to the cross bite, abnormal bite. So this can lead to primary TFO. So when TFO is a result from inability of the tissue to withstand the or to resist the occlusal forces, that is secondary TFO. You can see this in this picture. This tooth is unable to unable to withstand the occlusal forces, which leads to further bone loss. So that is called secondary TFO, and which can lead to pathologic tooth migration. So what is pathologic tooth migration? So any tooth displacement that results when balance among the factors that maintain the physiology tooth position is disturbed by periodontal disease. So if they cannot withstand the normal occlusal forces, this will get migrated. So any pathology condition which leads to this movement is called pathologic tooth migration, which is always associated with gingival inflammation and pocket formation as the disease progresses. You can see that in occlusal direction it leads to supraeruption. So either it can be migrated to the other mesial or distal side, and in supraeruption cases it will get supraerupted. You can see this in this picture. It is this tooth 2-1 got supraerupted due to pathologic migration. Coming to the mobility, all teeth have a slight degree of physiological mobility which varies for different teeth and different time. It occurs in two stages. So one within the socket, there is where the tooth moves within the confines of periodontal ligament can occur. And second stage is that which occurs gradually and entails elastic deformation of alveolar bone in the response to horizontal forces. So that is the secondary stage. So first one within the confines of periodontal ligament, the other one which entails the elastic deformation of the alveolar bone in response to horizontal forces. So this can be checked by either by one finger and one instrument, or by two instruments. So it is graded into grade 1, grade 2, grade 3. So what is grade 1? It is slight more than normal. Grade 2 is moderately more than normal. And grade 3, severe mobility, that is mesiodistally or facial-lingually combined with vertical displacement. So coming to the furcation involvement. So in rooted teeth, the possibility of furcation involvement should be carefully explored. So if there is involvement of furcation areas, if the periodontal disease reaches the furcation areas, that is called furcation involvement. So it can be checked by a specially designed probe called Neighbors probe, so which allows an easier and more accurate exploration of the horizontal component of furcation lesions. So you can see that the one probe is being used in this picture. You can see that one probe has been used for detecting the furcation involvement, but it may not detect the furcation involvement since it is in uh, straight order. Whereas you can see that in the second picture it is a curved one, that is the neighbors probe, which has been used to enter the furcation area. That is why it has exposed the horizontal component. So for the vertical component you can detect with the uh, probe, whereas for the horizontal component you need to use the neighbors probe. So under classification we are following Glickman's grading of furcations. So one, there is a incipient loss of bone in the furcation area, and in the grade 2, Glickman's grade 2 furcation is, that is intact one wall with uh, loss of one bony wall, which permits the entrance of probe inside and which acts as a cul-de-sac. And grade 3 is that which allows the passage of probe through and through, but it will be covered, one of the wall will be covered by soft tissues. Whereas grade 4 it is, which is allows the passage of probe through and through, but it will not be covered by soft tissues. Coming to the indices taken, the most important indices which we are taking for the Keshita are oral hygiene index simplified, modified sulcus bleeding index, and Russell's periodontal index. So, which help to assess the oral hygiene status and severity of gingival bleeding and assess the status of periodontium. So, which might predict the outcome of the treatment. So coming to the basic periodontal examination, so which is important, that is BPE. So which we will be assessing sextants, that is 17 to 14, 13 to 3, 24 to 27 region, and 34 to 37, 43 to 33, 44 to 47. So the scoring codes are 0, 1, 2, 3, 4, and star. So 0, 1, 2, that is pockets will be less than 3.5. With 0, no calculus or overhangs, no bleeding on probing. So the black band will be clearly seen that we are using WHO probe with like ball end with 0.5 mm with 3.5 to 5.5 color coding markings, 8.5 and till 11.5. So for this, if the pockets, the one is denotes that pocket if less than 3.5, so that black band will be seen. No calculus or overhangs with bleeding on probing. So first one is bleeding on probing. Two will be pocket will be less than 3.5 with overhangs, calculus overhangs. So 0 is quite normal. 1 with the bleeding on probing. 2 with the calculus or overhang. So black band entirely visible for 0, 1, 2. Whereas 3, the probing depth will be in between 3.5 to 5.5. So black band will be partially visible. So indicating that a pocket depth of 4 to 5 mm, which is mild periodontitis. Then the probing depth, if it is greater than 5.5, there is you are not like visible. The black band is totally disappears, which indicates a pocket depth of 6 mm or more. So if there is any furcation involvement, it is denoted as star. So there is the scoring codes under BP. So the guidelines for or guidance on interpreting the VP score. So zero, that is quite everything that is normal. So that is excellent prognosis. So no need for of periodontal treatment. If there is bleeding on probing, that means there is gingivitis. So oral hygiene instructions can be given and scaling can be done. Whereas where there is subgingival calculus overhangs and all, that is as for a cord one plus you can use like removal of plaque retentive factors including all supra and subgingival calculus. Then as for code 2, that is with the code 3, that is as for code 2 and root surface debridement if required. So there is mild pocket depth, so we can go for normal scaling and then root planing if needed. Then for the 4, that is if there is greater than 5.5 mm, that is a pocket of 6 mm is there. So then oral hygiene instructions with the normal scaling and then root planing. Thus is the need for more complex treatment. If it is needed, then refer to specialist. Then furcation involvement is there. Treat according to like VPE score 4 and assess the need for any complex treatment. Same like that, you have to refer to specialist for further treatment. So you can read on more on BPE on like using this link. Coming to the diagnosis, establishing the diagnosis of a specialized periodontitis is a process in which examiner utilize all the informations that we have assembled. They will evaluate it and will come to the diagnosis. So there are different diagnostic patterns, that is clinically healthy gingiva with reduced periodontium, that is with quite normal with reduced periodontium can be which can be due to the successful treatment which lead in stable periodontitis or non-periodontitis like cervical abrasion and crown lengthening also, and can be categorized into localized or generalized gingivitis, that is or periodontitis based on the sites involved. Localized if it is less than 30% sites involved, generalized if it is greater than 30% sites involved. So that is inflammation of the gingiva with bleeding on probing may indicate gingivitis. Then coming to the periodontitis, we will assess all the pocket depth, furcation involvement, recession, and we will come to the diagnosis of periodontitis, whether it's localized or generalized. Then we have to go for staging and grading according to the staging and grading criteria. As we have already covered the classification, so I am not repeating the same thing. Then coming to the prognosis also we have covered in separate chapter. Is the prediction of probable course, duration, and outcome of the disease. Based on that, we have to categorize as overall prognosis. And if any teeth like localized area, if it is involved, you have to go for individual prognosis also. Then categorize it as excellent, good, fair, poor, questionable, or hopeless. So coming to the treatment plan, this is the preferred sequence of periodontal therapy. We have this also we have already covered. So I am just making it like short. That is emergency phase, non-surgical phase, to maintenance phase. So under phase 4 therapy, it will go under phase 2, that is surgical phase and restorative phase, and again it will come to maintenance phase. So these are the phases of periodontal therapy. So what is preliminary phase? That is if any pain, that is abscess, all should be treated under this, and extraction of hopeless teeth should be also under preliminary phase. Non-surgical phase, that is cause related factors, that is phase 1 therapy. So non-surgical periodontal therapy usually comes under non-surgical phase. Then again evaluation after 2 weeks. If there is inflammation, you have to re-evaluation. To re-evaluate you have to re-evaluate the patient after 2 weeks. Then if it is indicated, then should be referred to referred for surgical phase. And if there is any restorative phase needed, you have to refer for phase 3, and then again coming to the maintenance phase. So under maintenance phase, we have already like studied under supportive periodontal therapy. So we have Merin's classification. So during the first year of the patient and uneventful healing, you can call up within 3 months and within 1 to 2 months for the first review, first year patient. And after that, you have to categorize according to the oral hygiene status and the periodontal condition. That is class A, that is excellent results. So that 6 months to 1 year. If there is like full good oral hygiene, minimal calculus, no other pockets, like no teeth less than 50%, then 6 months to 1 year. Once in recall the patient once in 6 months to 1 year. So class B, if there is any inconsistent or poor oral hygiene, heavy calculus with systemic diseases, and so many occlusal problems, prosthesis, then ongoing orthodontic therapy, dental caries, and with smoking patient, positive family history or genetic test has been positive. So anything like that, then you have to recall the patient once in 3 to 4 months. And class C, it's very poor results. It is generally poor results after periodontal therapy. Very like less response to the treatment with the all these factors. Then you have to call once in 3 months or once in like 1 to 3 months. So that is the maintenance phase. So coming to the, so we have discussed all the periodontal case sheet recordings, all the procedures, all the steps, and now we have come across with some of the case-based scenarios. So we have given three cases, and you have to read and like write down the answers and should report to the departments. So for case one, that is a 38-year-old Caucasian male, systematically healthy, non-smoker, reported to the clinic for regular dental checkup. You can see the first picture and second picture for the occlusal upper, and third picture for the occlusal uh, lower. Clinical features we have given like oral hygiene, good. Full mouth plaque score 10%, full mouth bleeding score 8%, generalized sulcus depth of less than 3 mm, no evidence of clinical attachment loss. BP scores also we have given. So this is a chart we have provided for step 1 BP and step 2, and you have to come to the correct diagnosis. So along with, you have to give appropriate mechanical plaque control aid for this given case patient, and also chemical plaque control agent. So we have already covered under plaque control both the mechanical and chemical plaque control agents. So coming to the case 2 study, there is a 29-year-old female patient who was referred from orthodontist for opinion on recession in relation to 1311212345. So oral hygiene is good. Full FMPS 10%, FMBS 15%, generalized sulcus depth less than or equal to 3 mm. Here attachment loss of 5 mm in relation to 3 and 3 mm in relation to 1 1 4 5, 2 mm in relation to 1 2 1 3, and RT type 1 gingiva recession for 1 3 1 1 2 1 2 3 4 5. So BP score has been given. So OPG also we have given, and this is the diagnosis chart. You have to record the, write down the findings and should come to the diagnosis. Select the appropriate mechanical plaque control agent and chemical control agent. Case 3 is a 3-year-old female patient wants to get her deposits removed, and this is the photo, the first photo with the label side, occlusal upper side and lower occlusal. Oral hygiene poor, FMPS 80%, FMBS 60%, generalized sulcus depth again less than or equal to 3 mm, no evidence of clinical attachment loss. BP score has been given. So you have to come to the diagnosis by writing the findings, and select the appropriate mechanical plaque control agent and chemical plaque control agent. So that's all for today. So to conclude, the eye see only what the mind knows. Information gathered from history and examination overwhelming when used correctly, which leads to solution or diagnosis as well as the solution. Data produced by comprehensive examination requires skill and attention to detail of examiner. Skill in diagnostic process requires constant learning. Initial dental student to experienced dental practitioner. Thank you.